Hello, everyone. Today we're going to talk about cardiovascular diseases, chapter 7 in your text, and for stroke on chapter 8, pages 289 to 294. So let's get to it. Cardiovascular disease, hopefully, as you've heard, it is the #1 killer of Americans, men and women. Sometimes we think that for women it's breast cancer. It is heart disease. So very important that we study it. The main reason that heart disease happens is because of the process of plaque buildup in the walls of the arteries over time. And this creates a risk for a heart attack and stroke. We call this plaque buildup atherosclerosis with the TH. Many different factors influence the development of atherosclerosis, and so we'll discuss what some of those are. Includes a multiple of different diseases and conditions as well, affecting the heart and circulatory system. So sometimes we say heart disease and we're including many other things. It could be specifically coronary artery disease, affecting the arteries that feed the heart muscle itself. Or it could be hypertension, high blood pressure, and we'll define today what we define as hypertension. Angina, chest pain, sometimes included in this as well. Peripheral artery disease, which is similar to what happens to the coronary arteries, but it's an arterial buildup of atherosclerosis that is happening on the extremities, away from the heart, away from the brain. Right? It's in the periphery, usually in the lower extremities. Congestive heart failure, when the heart muscle fails to function efficiently anymore. We call that congestive heart failure, so we'll take a look at that. Myocardial infarction, aka heart attack. When and how does that happen? And is it all the same? What are the differences? And what happens in a stroke, right? So we tend to group all of these conditions when we refer to cardiovascular disease. And you probably, knowing this, know someone or have heard of someone that has had some of these conditions affecting them. I will borrow a lot of information from the American Heart Association. That is a great source of information. They have a lot of information, not just for professionals, healthcare professionals as we are, but also for individuals that are being diagnosed with a condition of the heart or have had a stroke. Lots of educational videos and other lifestyle information, what to do to manage any of the signs and symptoms. So very, very helpful. In this field, if you're going to continue to practice or be in the healthcare profession like as we are, you will get regularly certified in CPR, either through the American Heart Association or the Red Cross. And there's other ones out there, and you will maintain that certification throughout your professional career. I like to, in a former life, I was a CPR basic life support instructor, so I don't think we can hear it enough. The common heart attack warning signs, any pain or discomfort in the chest or radiating pain. Sometimes people will hold the area that it hurts. You'll see them holding their chest or maybe their arm, and they look distressed. They may complain of lightheadedness, nausea, or vomiting. They could experience some jaw, neck, or back pain discomfort that is unusual, not like a typical pain that you have when it's muscular. Sometimes because the heart is tilted slightly towards the left side, they may have discomfort through that side, but it could radiate in other areas. And shortness of breath, as we define as SOB, shortness of breath, and not just the usual kind that you get with exercise or activity, but unusual shortness of breath, like you may get when you're very sick with a respiratory infection, shortness of breath. So not your typical, they obviously know there's some kind of different thing going on. So we want to look for those common heart attack warning signs. Another one that I like to talk about, when someone is struggling with chest pain and you ask them if they're still conscious, they will deny that it's a heart attack. That's a common thing for individuals to do because they're afraid that it could be. So if you suspect at all that someone may be having a heart attack, just go to another room, call 911 because we don't want to overstress them. Have them sit down and rest. If it's not a heart attack, it will pass. But if it is, it's going to keep coming, like a Mack truck. It will keep coming. So just go to another room and call 911. Let them know that you're suspecting a heart attack, whether or not the individual is conscious or unconscious. So go ahead and do that if you ever have the suspicion. The worst that can happen, the least that can happen is that they come over and they check the individual and there's nothing wrong, but at least we have better safe than sorry. If it is something wrong going on, they will take them at that point, and that's what we want to happen. Because the sooner that we can get them advanced cardiac life support, the better their chances are of surviving it with the least amount of damage to the heart muscle. So really important. And I may be saying this over and over again as we talk about cardiovascular disease today. So risk factors for coronary artery disease, we talked about these a little already when we talked about the ACSM risk stratification, the ACSM risk versus signs and symptoms. So we talked about it in the pre-activity screening already. We're just going to get into it a little bit in more detail today. So risk factors can be classified as modifiable or non-modifiable. So modifiable means that you can do something about them. It's related to a lifestyle habit. Non-modifiable are things that you're stuck with. We can't change them. So we just need to be aware of them and not try to pile on the ones that are modifiable. And then be proactive if you have a lot of the non-modifiables and getting screened and checked and making sure none of these non-modifiable risk factors are creating a disease condition. So that's what we do with that. Number one for modifiable, maybe you were thinking about it already, cigarette smoking. That's one. In order for it not to be a modifiable, in order to not be a risk factor, you have to have quit for 6 months. You also need to not be exposed to anybody that smokes in front of you, with you in the same room, right? So that's one. Cholesterol levels, so having a very high LDL, very high triglycerides, and having, I don't have it here for some reason, and having a very low HDL. So that's going to cause some damage to the arterial wall. So your lipids is why people check the cholesterol. We want healthy levels of cholesterol. We want the LDL to be low, triglycerides to be low, HDL to be high. That's what we're looking for, that ratio. High blood pressure, that's the blood that is exerted when the heart contracts. If it's too high, eventually that damages the arterial walls. And when you have damage, there's an immune system response, and that's what leads to eventual problems with the plaque buildup over time, as we talked about atherosclerosis, ATH, right? Diabetes, uncontrolled diabetes, right? So here's the good news about diabetes. If it's well managed, individuals that know their numbers all the time, maybe you heard us know their numbers, and are proactive, exercise regularly, eat as they should, they take their medications as they should, then if they keep that healthy range, the Goldilocks range of blood sugar, then that damage doesn't happen to the arterial wall. So that's why it's in the modifiable category. Even people with type 1 diabetes, right? It's in the modifiable, because if you are proactive about it, then your risk is reduced. Sedentary behaviors is next. So spending, and this is not just being sedentary, where you do not do any physical activity, but spending, you could do an hour of exercise a day, but if you spend the next other 23 hours doing nothing, extensive sedentary behaviors, we know is an issue. So this is why you see the tracking devices, your Fitbit, your Apple Watch is telling you, your phones telling you to move if you sat for longer than about an hour. Ideally, you're moving every 45 minutes or so, right? So you're doing an activity. So prolonged sitting or sedentary behaviors we want to limit that. And that again is modifiable. You can look at your schedule and change it. One of the things I've been doing lately is at the end of every hour, I engage in about 10 minutes, if I'm working from home, of doing some type of cleaning in my house. And so in an 8-hour day, I've done a lot of cleaning, which I don't really like to do all at once. So, and that gets me up, it gets me doing something else, and I can complete a lot of tasks in one day. So that's it for me. Maybe you don't want to do that, but maybe you can do something else that is active, you know, in your household. Okay. So another one that's important, exercise history. And as exercise activity increases, your risk of coronary artery disease, cardiovascular disease is reduced. So we know that. And physical activity throughout your day. Remember, activities of daily living is the bottom of the pyramid, together with engaging activities of cardiovascular nature, strength training and flexibility, and neuromotor. So including all those as recommended throughout your week. So you're getting your cardiovascular exercise requirement, you're getting your strength training 2-3 times a week, you're getting your flexibility 2-3 times a week, and doing some neuromotor types of activities 2-3 times a week. All of that leads to reduced risk. Then the non-modifiable, we can't do anything about our age. The older we get, the higher the risk. So if you remember from the pre-activity screening lecture, men 45 and older, that's going to be a positive risk factor, and women 55 and older, that's going to be a positive risk factor. And unfortunately, we can't do anything about that. And this is based on chronological age, not biological age. So it is what it is. And the older you are, the more chances you've had for the arterial walls to be exposed to damage and plaque buildup over time. It's just what it is. Some people do better based on the lifestyle to prolong when that happens, or slow it down, so that happens way later in life, but it's going to happen. Gender, men are a little bit higher risk based on their hormonal levels. For women, though, after menopause, there's some changes in estrogen that also lead to having an increased risk as well. So there's some differences when it comes to that, where males accumulate, typically speaking, body fat tends to be in the central region, so they tend to have more of the android, apple shape, versus women that tend to be more gynoid or pear shaped. Not always though, but so that's why some of those reasons go with that hormonal and some other topic differences, apple shape, all of those things, or a pear shape. And then certainly we can't do anything about our family history, right? And this cuts always, right? So if you want to be a great elite or Olympic athlete, you know, they famous sociologist says you better choose your parents wisely. Well, same when it comes to risk for cardiovascular disease. Family history does play a part. If not one older adult in your family in their 70s or 80s has something, but if a younger adult, a parent had a heart attack in their 40s, right? That's a significant risk factor. Okay, so if it happens at a younger age, older adults, you know, over 65, things are going to happen. So hopefully this is just a refresher of what we talked about for screening. We still do not use these for medical clearance. It's just to know your numbers, know your risk. And if you have any of these that you can move out of the categories as risk factors, we're going to move them out. Okay. All right. So what do we know about cardiovascular disease and exercise? If you were to take a guess, okay, what would you say? Well, I'm going to put it out here for you. Exercise that is carefully planned and monitored is one of the best therapies, provided precautions are taken. So exercise is going to improve the conditioning of the heart. The heart is a muscle, right? Training makes it more efficient, in particular your left ventricle. So as you improve your VO2 max through training, as you improve the efficiency of your heart muscle to deliver blood to every part of the body, activities of daily living become easier, as and your ability to get through everyday life is going to be easier, and you're going to improve things like your cholesterol, blood sugar regulation, all the things that we talked about, and certainly your weight, all right? Obesity as well. All right. ACSM screening for diagnosed cardiovascular disease. So again, going back to the algorithm, right? So think about that. So now you have someone that has a cardiovascular disease. So that is a CMR. So if they are diagnosed with a cardiovascular disease, we're going to say yes for a CMR. So remember that. For first, if they have if they have no physical activity history, more than likely medical clearance is recommended because they have a CMR, right? If they are physically active, right, only for vigorous. If you remember the three decisions, physical activity, yes or no. So they have a CMR, right? They're not physically active. You're gonna refer them to go get a physical before becoming more physically active. And the benefit of that is that we're gonna get back recent information on how they're doing on their health profile before we engage in exercise. And we're going to get to communicate with their physician and other healthcare providers, right? So if someone, maybe they had a heart attack a few years ago, then they failed to go back to the doctors for whatever reason, now that's going to establish that communication, and we're going to get more detailed information about our client. And we can make decisions about whether or not we're going to continue to work with them, or if we feel that they should be referred to a higher level of care training. Okay. If they are experiencing signs and symptoms, like they're having chest pains, that's the stuff on the yellow box. If they're having chest pains, if they're having shortness of breath, they feel like they're going to faint, any of those, pain, discomfort in the chest, neck, jaw, all of these are signs of a heart attack, we're going to refer them immediately. Not pass go, do not collect $200, okay? So if yes to any of these, we're going to obtain medical clearance for all. Okay, good. Even if they are physically active. And this could happen at any time. Like they could show up for training and say that this morning they were feeling these things. We're going to ask them, well, you should call your doctor's office, let them know how you're feeling, or follow up on that. Okay, if you suspect that it's a heart attack, have them sit down, go to another room, call 911. Okay, good. All right, having a little trouble getting to the next slide. So just to remind you here, just bringing this back, physical activity history determines your path. For someone with cardiovascular disease, they have a CMR. So they are, if they have no signs and symptoms, we could do moderate and light and moderate. If they are having signs and symptoms, no, stop, get medical clearance. On the other side, if they're not physically active and they have a CMR, it doesn't matter. We're not going to do any type of activity if they're not physically active. We have not said yes to physical activity. We're going to need clearance. So just to make sure we got that straight. Okay. All right. So now let's review just a little bit of anatomy of the heart that you probably have looked at before. I'm sure it's not new to you. Major blood vessels, make sure you understand what those are. So we want to know the superior vena cava, inferior vena cava. We're talking about how the blood gets into the heart muscle itself. So I'm not talking here about what feeds the heart muscle itself. Sorry, I'm talking about how the blood gets to the heart so that the heart can work as a pump. All right. So the heart is a very efficient pump. We don't have to think about it beating. It does it on its own. It has its own electrical system. So it doesn't work like muscles that it has to come from the central nervous system immediately. It has its own little conduction system. It doesn't need our control. We don't have to think about it, which is kind of cool, right? We can certainly affect it if we do some meditation and all that, but we don't have to think about it beating all the time to keep us alive. So here we're talking about major blood vessels that bring blood from the body to the heart and take blood to the lungs and bring it back from the lungs. So know your superior and inferior vena cava and how they return blood into the right atrium. And then from the right atrium, it travels to the tricuspid valve into the right ventricle. And then think about what the right ventricle has to do. Right ventricle has to pump the blood away. All right. So away means it's going to be an artery away from the heart. It's going to go through the pulmonary artery into the lungs to drop off carbon dioxide and pick up oxygen based on pressure gradients. This is how this happens. So based on as it gets into the lungs, you're going to have lots of oxygen. The blood, it's going to have low pressure of oxygen. So then it diffuses. Through the diffusion, we release the CO2 and bring back some of the O2, and it returns back into that left atrium. Now it's coming back into the heart. So it's a vein, pulmonary vein. It comes back into the left atrium, travels through the mitral valve or bicuspid valve. The valve has two things in it. That's why bicuspid. Tricuspid means three little valves in there. Right? They're one-way valves, and that's how they should function. They don't always do that. Sometimes they don't, and that's a problem. That can lead to cardiovascular issues. Then it goes into the working part of the heart, the work muscle, the left ventricle. And the left ventricle's job is to pump blood to the entire body. With training, it becomes more efficient. It becomes stronger. That's meaning that it hypertrophies and it's like a skeletal muscle, and it can squeeze more blood out. And since it can squeeze more blood out, right, it may not have to eventually beat as frequently as a heart that cannot squeeze as much blood out. It also becomes more flexible, meaning that it can stretch out further. Frank Starling principle with training. So if it can come out further to let more blood to fill it, that blood, high pressure oxygen blood that's coming from the lungs, right, it can allow more blood to fill it. Then when it squeezes, because it's so buff, as with training, it can squeeze so much more blood out, right? It's a lot, it can take a little break. And this is why one of the adaptations that we see with training, that at any sub-max intensity, the heart doesn't have to beat as hard as frequently to maintain the same cardiac output. All right, so if that 6-minute mile that would elicit 150 beats per minute when you first began training, after training, then the same 6-minute mile, the same incline now elicits 130 beats per minute. So you can maintain the same amount of blood delivery to the muscles, but at a lower heart rate. So that's one of the easy ways to detect training adaptations. You see that something that used to raise your heart rate so high, now it doesn't do it because you become accustomed to it. And what's happened is your left ventricle has become stronger. So that's awesome. All right, so know that kind of blood flow, how the blood flows through the 4 chambers of the heart. Where does it go, and which vessels are doing? Oh, I forgot the big one. So how does the blood leave the left ventricle? Through which vessel? Aorta. And there's a valve there too. And sometimes that becomes damaged for some people with cardiovascular disease, and it has to be replaced. For example, Arnold Schwarzenegger, because of his drug use for bodybuilding, that's one of the things he damaged in his heart. And he's had like 3 surgeries to replace that, right? So that's also important to know. So the aorta, ascending, descending, right? Ascending goes towards the top, descending goes towards the bottom, right, of the body, but very important too. And the aorta sometimes gets damaged because it takes so much pressure over time. So that could be damages there. When we're talking about cardiovascular disease, it can happen anywhere in the system. So make sure you're comfortable with that blood flow. It's important that you play around with it and are comfortable. If you haven't learned it, learn it now. You will be tested on that in your certification exams, and I may ask questions on that for sure. So know your blood flow. Okay. Coronary arteries. So now these are the arteries that actually feed the heart muscle itself. Being the fact that the heart controls is the pump, it gets fed first. It gets the blood first. So let's take a look at some of these. The heart receives oxygen-rich blood from the coronary arteries. Vessels branch out from the initial segment of the aorta. We said the aorta is responsible for bringing blood out of the left ventricle. So it's right there. So the heart goes, no, first you got to stop. First you have to, your first drop off is right here. Okay. We get the first take. So right there. Then 4 major coronary arteries help out to make sure that the heart gets all its blood supply and oxygen, of course, right coronary. Then we have the left main coronary, and then we have the left coronary artery and the left circumflex there towards the bottom, and the left anterior descending. All right, so we're not going to learn all the details that you probably learned in anatomy and physiology. This is all what we need to learn for this class. Okay, so make sure you're comfortable and can identify these areas and where they are. Coronary artery disease then, okay, affects the coronary arteries which supply the heart with blood. So these, when we talk about CAD, it's a specific type of cardiovascular disease that affects the arteries that supply the heart muscle itself. That's what we're talking about with CAD. So I know sometimes we use it interchangeably. Cardiovascular disease is a big umbrella term. Coronary artery disease is more specific. Just like peripheral artery disease is more specific, it's talking about the periphery having damage in arterial, in the arteries. So it affects the coronary arteries, which supply the heart with blood. Coronary artery disease can be stable angina pectoris. We'll talk about what that is. Unstable and basically chest pain. Stable chest pain, unstable chest pain, or a heart attack. Yeah, a heart attack is when there's a complete blockage to one of these coronary arteries and part of the heart muscle is not getting oxygen. And so that causes pain. Ischemia, that is ischemia, lack of oxygen flow to a certain part of the body. Whatever it happens, it's going to cause pain when there's no oxygen there. And when there's a complete blockage, that's what's going to happen. So let's take a look at coronary artery disease. It's basically atherosclerosis in the coronary arteries. So it's a buildup of plaque over time in the coronary arteries. And as activity increases, if you have this kind of blockage that we're seeing here, that part of the heart muscle is not going to be able to get, it's kind of like you have a traffic jam. Think of I-4. You're not going to get to your destination as quickly as you thought. And so you're going to have to increase your time. So it's not going to, you're going to have to take a break. It's not going to work out. Or you're going to have to maybe go through a different way. This is the most common form of heart disease. It's associated with the coronary artery disease. And there's going to be different levels depending on how much of a narrowing has happened here based on the plaque buildup, how much of a blockage we have. Once you get a full blockage, that's going to be a heart attack. Depending on how large the artery is that was blocked, more severe, right? So if it's one of the top ones, right in the right coronary artery, for example, that's feeding a big part of the heart, is a big entryway, you're going to have significant damage. If it's one of the smaller collateral ones that keep getting into smaller areas, maybe not as severe. So that's going to be important as well. That's why not every heart attack is going to be the same. Okay, so I am going to pause here. We're going to continue on now that we've discussed atherosclerosis. We're going to discuss atherosclerosis in more detail in my next video. All right, so let me pause it here. Make sure you continue to watch.